Okay, good day everybody. I'm Dr. Alvin Brian Velasco, a gastroenterologist from the Department of Medicine. For today, we'll be discussing gallbladder and biliary diseases. For our objectives, we'll be discussing bile and biliary secretion, the pathophysiology of gallstone formation, diagnosis and management of gallstone diseases, the complications of gallstone disease. Then we'll proceed with choledocholithiasis and its complications. And lastly, we'll discuss briefly biliary strictures. So first, let's talk about bile. So bile, as we all know, is an isotonic fluid. Now, it has major solute components comprising of bile acids, lecithin and other phospholipids, and also cholesterol. We know that most of the cholesterol is excreted via the bile. The daily secretion is around 500 to 600 ml. There are three main mechanisms for the regulation of your bile secretion. First is active transport of your bile acids from the hepatocytes to your canaliculi. You have the active transport of organic anions and cholangiocellular secretion, which is secretin mediated and energy dependent because it is cyclic AMP dependent. So from the hepatocytes, the bile is actively transported into the bile canaliculi and drained into the canals of Hering. From the canals of Hering, this will flow into the different interlobular ducts that would coalesce to form your larger bile ducts. Okay. Now, you have then your right and left hepatic duct, which would coalesce to form the common hepatic duct. Now, the common hepatic duct together with your cystic duct will form your common bile duct. And the common bile duct will drain into the second portion of the duodenum via your ampulla of Vater. In enterohepatic circulation, so the bile, after it was released from the bile duct into the small intestine, so it will traverse the length of the small intestine to reach the terminal ileum where it is reabsorbed. So it goes into the hepatic portal vein, and from there it goes into the liver and taken up by the hepatocytes. Now, for the 5% of bile salts are actually excreted in your feces. Okay. There are three types of bile acids found in the body. So the primary bile acids are synthesized from cholesterol in the liver. So they are conjugated with glycine or taurine. And the primary bile acids are your cholic acid and chenodeoxycholic acid. Now, the secondary bile acids are derivatives from your primary bile acids. So they are formed in the colon as bacterial metabolites of primary bile acids. The two types of secondary bile acids are your deoxycholate and your lithocholate. And a tertiary bile acid is your ursodeoxycholic acid, which is an epimer of your chenodeoxycholic acid. Let's not go to gallstones. So gallstones are quite prevalent worldwide. In fact, even in our country, we have a very high prevalence of gallstone disease. In the US, the prevalence is around 8% in men and 17% in women. Gallstones are formed due to abnormal bile composition. And there are two main types of your gallstones, the cholesterol stones and your pigment stones. And later, you'll know that pigment stones would be further subdivided into your brown pigment stones and your black pigment stones. Majority of gallstones are cholesterol stones. So for cholesterol stones, they are made up of more than 50% cholesterol plus calcium salts, bile pigments, proteins, and fatty acids. They can be solitary or multiple. They can grow to large sizes. They can be smooth or faceted, as shown in the pictures. On the other hand, pigment gallstones have less than 20% cholesterol. They can be multiple also or irregular in size. So they are classified as black or brown pigment stones. Black pigment stones are comprised mainly of calcium bilirubinate with mucin glycoproteins, while brown pigment stones are more of calcium salts of unconjugated bilirubin. Bile sludge is a thick mucous material made up basically of lecithin cholesterol liquid crystals, cholesterol monohydrate crystals, calcium bilirubinate, or mucin gels. So they form a crescent-like layer at the dependent portion of the gallbladder with no acoustic shadowing. Now this feature is very important to distinguish bile sludge from your gallstones. However, bile sludges are known to be precursors of your gallstones. For the pathogenesis of your gallstones, so any abnormality in your cholesterol, bile acids, or lecithin levels can trigger the formation of gallstones. Whether it be an increase in your cholesterol levels, a decrease in your bile acid pool, or a decrease in your lecithin, all of this can lead to supersaturation of your bile. Now, we have different pronucleating and anti-nucleating proteins. For pronucleating proteins, we have your mucus glycoproteins and heat labile proteins, while your anti-nucleating proteins are your apolipoproteins and lecithin vesicles. So any imbalance between the pro and um, anti-nucleating proteins can lead to nucleation of your vesicles, and the nucleation of your vesicles would lead to microstone formation and eventually gallstone formation. So in terms of mechanisms in the formation of your lithogenic bile, so as you know, in cholesterol metabolism, cholesterol is bound to your phospholipid to form micelles or vesicles. Now these vesicles would eventually form liquid crystals and nucleate to form solid cholesterol monohydrate crystals. The growth of these crystals occurs by direct nucleation of cholesterol molecules from supersaturated unilamellar or multilamellar biliary vesicles. In terms of mechanisms for lithogenic bile, the most important would be the increase in biliary secretion of cholesterol. Okay, so the risk factors for this would have your metabolic syndrome, a high calorie or cholesterol diet, and also genetic predisposition. So other mechanisms, you have nucleation of your cholesterol monohydrate crystals. So again, that's what I was discussing a while ago. There's an imbalance between pronucleating and anti-nucleating factors. No? And the other mechanism is gallbladder hypomotility, wherein you have an abnormality in gallbladder emptying. For pigment stones, there is increase in concentration of your insoluble unconjugated bilirubin in the bile, abnormal motor function of the gallbladder, and decrease in your bile salts. The risk factors for the development of cholesterol stones would include demographic and genetic factors, metabolic syndrome and obesity. For rapid weight loss, there is utilization of your adipose tissue, thereby increasing secretion of your cholesterol. For pregnancy, progesterone was shown to be an inhibitor of gallbladder motility, increasing age, gallbladder hypomotility by other factors. You have drugs like clofibrate and also female hormones like your estrogen would also increase biliary secretion of cholesterol. Risk factors for pigment stones include also demographic and genetic factors. For black pigment stones, the most common risk factors are hemolysis and hemolytic disorders, and also liver cirrhosis. Other risk factors include pernicious anemia, cystic fibrosis. For brown pigment stones, the most common risk factors are biliary tract infections. So other risk factors would also include increasing age and ileal disease resection or bypass. For the clinical presentation, majority of patients with gallstone disease are usually asymptomatic. Now, when symptoms occur, this is usually due to inflammation and obstruction in the cystic duct or the common bile duct. So this can be accompanied by nausea, vomiting, or sometimes there's a feeling of bloatedness. Now, the classic presentation of gallstone disease is a severe, steady ache or fullness in the epigastric area or the right upper quadrant with radiation to the interscapular area. So this is termed your biliary colic. So this is defined as a sudden, steady pain lasting 30 minutes to 5 hours, subsiding suddenly or gradually. Now this is a misnomer because when we talk about colic, the characteristic description is a waxing and waning type of pain. It goes on and off. While for biliary pain, this is a sudden, steady pain. For the diagnosis of gallstones, the gold standard is your ultrasound, which is relatively cheap and is readily available. It has a 90 to 95% sensitivity and 98% specificity. Ultrasound can detect gallstones as small as 1.5 millimeters. Now, the characteristic findings of gallstones on ultrasound is your classic acoustic shadowing and the change in position wherein during ultrasound, usually gallstones would change or shift in position as compared to gallbladder polyps. So this characteristic is very important for you to differentiate polyp from gallstones. Now, CT scan can also be done, but it is less sensitive to sludge and stone, but also because it is more expensive. Now, this slide shows us the difference between gallstones and bile sludge on ultrasound. The image on your left shows the gallbladder with a hyperechoic structure, round structure, inside its lumen with posterior acoustic shadowing, which is a characteristic of your gallstone. Now, the picture on your right, so as you can see, there's an area of hypoechogenicity inside the lumen of the gallbladder with no acoustic shadowing. It forms a crescent shape, so this is characteristic of your bile sludge. So another imaging modality that can be used to diagnose gallstones is your plain abdominal film. So stones with sufficient calcium are radio-opaque on your X-ray film. So when we say radio-opaque, they appear as white on your X-ray. So this can be seen in 10 to 15% of cholesterol and 50% of pigment stones. Another is your radioisotope scan or HIDA scan, which is rarely used today, but it is useful to detect cystic duct obstruction. For management of gallstone disease, so this is divided into medical and surgical management. For medical management, we can try your oral dissolution therapy using your ursodeoxycholic acid, which, as you can recall, is a tertiary bile acid. The dose is given at 10 to 15 milligram per kilogram per day. Now, your criteria for dissolution therapy would include a radiolucent stone. So this should not be a calcified stone as seen on X-ray. Then, the smaller the stone, the better chance of dissolution. You must also have a functioning gallbladder and cystic duct, meaning there should be no previous history of complications. And also, they should be cholesterol stones because pigment stones would not work with ursodeoxycholic acid. Now, the success rate is around 50% in 6 months to 2 years with a 30 to 50% recurrence after 6 months. The mainstay of management for symptomatic gallstone disease is still surgery. So for patients presenting with severe abdominal pain with disruption of their daily activities, those who had prior complications like cholecystitis and acute pancreatitis, for those underlying conditions predisposing to complications like porcine gallbladder and limy bile, so these are all indications for the patient to undergo surgery, and the gold standard is laparoscopic cholecystectomy. Okay. So for complications of cholelithiasis or gallstones, you can have the most common acute cholecystitis, and from cholecystitis you can develop empyema, hydrops, gangrene, or perforation. As you have choledocholithiasis, or the gallstone migrated from the gallbladder to the common bile duct, and a complication of which you can have cholangitis. Then you have your Merit's syndrome, You can have acute pancreatitis, fistula formation, gallstone ileus, porcelain gallbladder, and limy bile. For acute cholecystitis, so basically this is an acute inflammation of the gallbladder wall secondary to an obstruction of the cystic duct. So there are three main mechanisms for the development of acute cholecystitis. So one is mechanical inflammation. This is secondary to the increase in the pressure in the gallbladder, secondary to the obstruction of the cystic duct. Then you have your chemical inflammation. The obstruction would trigger the release of your lysolecithin, triggering further the inflammatory cascade. And of course, the bacterial inflammation. So you can have secondary infection inside the gallbladder, and the most common organisms are your E. coli, Klebsiella, and Streptococcus. For the clinical manifestations of acute cholecystitis, you have the classic triad of biliary pain or colic, the fever, and leukocytosis. This can be accompanied by nausea, vomiting, and bloatedness. Now, sometimes patient may also develop jaundice, but it's not common. The classic physical examination finding in acute cholecystitis is your Murphy's sign. So Murphy's sign, as you can recall, is when the patient would develop pain and there's a rest in inspiration when the examiner would palpate the right subcostal area. So how do we diagnose acute cholecystitis? Of course, you should have a very good history and physical examination. Okay. On laboratory, the key feature is an elevated WBC with predominance of segmenters. You may have elevated liver enzymes like your transaminases, SGPT and SGOT. On ultrasound, okay, you can visualize the gallstones. Then the main features of cholecystitis on ultrasound are your thickened gallbladder wall and the presence of pericholecystic fluid. Then you have your sonographic Murphy sign, which is elicited during ultrasound when you press the probe on the right upper quadrant. For management of acute cholecystitis, we usually place the patient on nothing per orem. Then we start the patient on IV antibiotics to cover for the most common organisms. And basically, the most important part of management is still surgery. You can do laparoscopic cholecystectomy or open cholecystectomy in special cases. This image is just to show you how laparoscopic cholecystectomy is done. Acalculous cholecystitis occurs when you have evidence of cholecystitis in your patient without an evidence of gallstones. Okay? So there's an increase in incidence of necrosis, gangrene, and perforation for these cases, and the mortality is high at 50% for those who have delayed treatment. Now, the risk factors would include elderly, debilitated, and critically ill patients, prolonged fasting, those who have serious injuries like burn patients and trauma patients, postpartum and postoperative patients, and also those who have systemic diseases like diabetes mellitus and tuberculosis. So the key is early diagnosis and treatment. For the pathogenesis or etiology of your acalculous cholecystitis, so you can have bile sludge, you can have vasculitis, the presence of a gallbladder adenocarcinoma, diabetes mellitus, torsion of the gallbladder, and unusual infections like bacterial or parasitic infections. Meniere's syndrome occurs when the gallstone impacts itself at the cystic duct, causing obstruction of the common bile duct. So not only does the patient present with biliary colic, but the patient would also present with jaundice. So because there's obstruction, you need to do ERCP with stent insertion, or you have to send the patient to surgery. Gallstone ileus occurs when there's mechanical intestinal obstruction secondary to a passage of a large stone in the intestine. So usually this is secondary to a fistula from the gallbladder to the intestine. The most common site of obstruction is the ileocecal valve, which is the narrowest portion of your small intestine. To diagnose gallstone ileus, we have the classic radiographic triad of pneumobilia, which is air found in the biliary tree, a calcified gallstone seen at the right lower quadrant, and dilated intestinal segments with air fluid levels or signs of obstruction. The management for gallstones ileus is surgery. Okay, so let's now go to biliary diseases. Okay. To image the bile ducts, we can use a wide array of diagnostics and imaging modalities. So the first is ultrasound, where you can visualize the intrahepatic ducts, but the sensitivity to detect choledocholithiasis in the common bile duct is very low. Next, we can use also CT scan. The next one is MRCP, which is magnetic resonance cholangiopancreatography, utilizing MRI to visualize the bile ducts and the pancreatic duct. ERCP is reserved basically for therapeutic purposes. Percutaneous transhepatic cholangiography and the therapeutic equivalent is percutaneous transhepatic biliary drainage is used when ERCP has failed. And the last one is endoscopic ultrasound, wherein a scope with an ultrasound probe attached at its end is used to visualize the bile ducts and the pancreas. Choledocholithiasis occurs in 10 to 15% of cholelithiasis. So it increases with age. In fact, 25% of elderly can have choledocholithiasis after cholecystectomy. Usually the presentation is either biliary colic or jaundice, and sometimes they can present with cholangitis. So they can be asymptomatic, especially if there are very small choledocholithiasis that they can easily pass out in the duodenum. Now, you have primary bile duct stones that can appear or form de novo in the bile ducts, and these are brown pigment stones. Now, a complication of choledocholithiasis is cholangitis. So, at least this is caused by partial obstruction to the flow of bile. Now, it has been shown that bile culture has bacteria in around 75 of patients with cholangitis. So what are the signs and symptoms of cholangitis? So we have the classic Charcot's triad. So this is made up of your biliary colic, jaundice, and spiking fever. Now take note, for it to be considered Charcot's triad of cholangitis, it should follow this following sequence. So it should start with biliary colic when the choledocholithiasis would obstruct the biliary tree. Therefore, there will be an increase in pressure in the bile ducts. Then this will be followed by jaundice because of the obstruction, and this will be followed by fever, no, with secondary bacterial infection. Now, in Raynaud's pentad, this is seen in patients with acute suppurative cholangitis. So the presentation is the classic Charcot's triad plus the presence of septic shock and altered mental status. So how do we treat patients with cholangitis? So we place the patient on nothing per RM. We correct the electrolytes and start the patient on IV fluids. We start the patient on IV antibiotics, broad spectrum antibiotics to cover for the organisms. But the goal is to decompress the bile duct, and the modality of choice is to do ERCP. So via ERCP, we can do stone extraction to relieve the obstruction, or we can place a stent, okay, to produce drainage. If ERCP is unsuccessful, then we can do percutaneous transhepatic biliary drainage, and this is done by our interventional radiologist. And if this is not available, then our last resort is to do surgery. Okay. These two images are from an ERCP. As you can see, the one on your left So upon injection of the dye, they were able to see three filling defects inside the common bile duct as shown by your yellow arrows. Now the image on your right, so they were able to remove the stones using a basket. So they were able to decompress the common bile duct and establish drainage of the bile back to the duodenum. Biliary parasitism can cause chronic recurrent cholangitis. The most common, at least in our country, is biliary ascariasis. But in other countries, they have Clonorchis and Opistorchis parasites that can invade the biliary tract. So we can do cholangiography, and the therapy is ERCP. Okay? And of course, we don't forget giving of antihelminthic therapy. So we can have benign and malignant obstruction of the bile ducts presenting as strictures. So for benign strictures, so common causes would be TB and post-surgical trauma. So TB can affect any part of the biliary tree, producing strictures anywhere in the bile duct. Post-surgical trauma, this occurs during cholecystectomy, sometimes upon ligation of the cystic artery. Part of the blood supply to the bile duct can be compromised, producing necrosis of that area and eventually producing strictures. Okay? Though very rare, there can be instances wherein there's also inadvertent ligation of the common bile duct during cholecystectomy, also producing a stricture. For malignant strictures, so cancer of the bile ducts is termed cholangiocarcinoma. So this is a primary cancer occurring inside the bile duct, producing strictures. Now for periampullary carcinoma, so what happens there would be extrinsic compression of the bile ducts. So this can occur with pancreatic cancer, ampullary cancer, or duodenal cancer. So other malignant strictures, you can have metastatic lesions, like for example, lymph nodes, no, that can also obstruct the bile duct, secondary to extrinsic compression. So treatment is ERCP with stent insertion or surgery. Okay, thank you very much for listening.